Welcome to this explainer. You know, when we usually think about heart failure, we picture it as the end result of blocked arteries, high blood pressure, or maybe some inherited genetic defect. But what happens when the heart muscle is directly attacked by outside forces, metabolic imbalances, or even the massive physiological shifts of pregnancy? Today, we're diving into the fascinating pathophysiology of acquired, non-genetic causes of dilated cardiomyopathy. We're going to explore exactly how these hidden culprits target the myocardium and fundamentally break down the heart's structure.
So let me ask you a question. Can a broken heart actually physically change the shape of your heart? Now, I know that sounds like a metaphor straight out of a poem, but as you'll see by the end of this, extreme external factors and intense emotional stress can rapidly and visibly alter the heart muscle. No joke. We're going to unpack the exact clinical mechanisms behind this, moving all the way from toxic chemicals to metabolism to pregnancy, and finally to emotional stress itself.
All right, before we get too deep, let's make sure we're on the same page. What exactly is dilated cardiomyopathy, or DCM? Essentially, it's a condition where the left ventricular systolic function goes down, usually while the actual dimensions of the ventricle go up. Simply put, the heart's main pumping chamber gets weak and it gets enlarged. It goes from being a tight, efficient mechanical pump into kind of a baggy, inefficient one. Now, while a lot of cases are tied to prior viral infections or specific genetic mutations, the cases we're zeroing in on today are triggered by very distinct and honestly surprising acquired factors.
So our whole framework for today boils down to this: triggers and targets. We're investigating exogenous stressors, meaning stuff from the outside world like toxins and drugs, and endogenous stressors. Those are the massive internal physiological shifts like metabolic disease and pregnancy that act directly upon the heart muscle to cause it to fail.
Here's our roadmap for today. First, toxic triggers. Second, metabolic causes. Third, peripartum cardiomyopathy. And fourth, the incredible phenomenon of Takotsubo, or stress-induced cardiomyopathy. Let's get right into it.
Section 1. Toxic triggers.
Now, cardiotoxicity can happen with a whole bunch of agents, like certain chemotherapy drugs, for example. But the most common trigger for chronic dilated cardiomyopathy is actually widely consumed socially. Greater than 60 to 80 grams, that's the amount of daily pure ethanol, which roughly works out to about 750 milliliters of wine, a six-pack of beer, or a half pint of hard liquor. When that amount is consumed daily for over 5 years, that is the threshold historically associated with alcoholic cardiomyopathy, though it's really important to note that women can actually develop this with lower amounts of alcohol. Basically, chronic heavy exposure messes with the heart's metabolism, protein synthesis, and oxidative stress. But here's the real puzzle, right? Not every heavy drinker develops heart failure. So, why is that?
Well, it all comes down to what we call the second hit concept. We now know that triggers like alcohol often unmask a hidden genetic vulnerability. Think of it like a trapdoor. In fact, mutations in the TTN gene, which is a gene absolutely crucial for heart muscle structure, are found in about 10% of patients with presumed alcoholic cardiomyopathy. So the toxin is basically acting as the environmental catalyst. It's the second hit that pushes a genetically susceptible heart right over the edge into failure. It is just a brilliant illustration of how our genes and our environment interact.
Okay, so how do we actually fix this? Step 1 is absolutely critical. You have to immediately remove exposure to the offending toxin, whether we're talking about alcohol or even heavy metals like cobalt. Step 2 is starting standard medical therapy for heart failure with reduced ejection fraction. And step 3 is making sure we prevent any further second-hit insults, things like atrial fibrillation or high blood pressure. The really great news here, once that toxic exposure is totally removed, many of these patients can actually improve to near normal heart function. It's pretty amazing.
Moving right along to Section 2, Metabolic Causes.
Let's shift our focus to what happens when our internal chemistry goes completely off the rails. Take a look at this endomyocardial biopsy. It's from a patient with hemochromatosis, which is an iron overload disorder. The tissue is stained with Prussian blue. You see all those dark blue areas? That is extensive iron deposition literally packed inside the cardiac myocytes. It physically jams up the cellular machinery. Now, we usually diagnose this by using an MRI to quantitate the iron, and if we catch it early enough, repeated phlebotomy or iron chelation therapy can actually pull that iron out and improve cardiac function before we lose too many of those precious heart cells.
Another massive metabolic culprit is the endocrine system, specifically the thyroid. Now, hyperthyroidism doesn't usually cause clinical heart failure all on its own in a normal heart, but it severely exacerbates existing heart failure. And here's a crazy paradox for you. The most common reason we see thyroid abnormalities in cardiac patients nowadays is from taking amiodarone. That's a drug used to treat arrhythmias, but it happens to contain a huge amount of iodine. The combination of hyperthyroidism and heart failure is highly dangerous. It requires extreme caution. You have to go incredibly slow in escalating medication because a patient can decompensate super fast.
Okay, Section 3, Peripartum Cardiomyopathy, or PPCM. This condition usually hits during the last trimester of pregnancy or within those first few months after delivery, and it actually affects up to 1 in 1,000 deliveries in the US. The pathophysiology is wild. It's often described by the vasculo-hormonal model. So during pregnancy, you have these massive hormonal shifts and tons of secretory products coming from the placenta, right? Well, in PCPM, we see abnormal anti-angiogenic signaling. Basically, the placenta secretes inhibitors that actually block blood vessel growth. On top of that, an abnormal cleavage fragment of the nursing hormone, prolactin, jumps in and decreases the vascular response right when the body is dealing with the natural oxidative stress of pregnancy. It is just a perfect storm of hormonal and vascular changes that basically targets and impairs the heart.
But wait, remember that second hit concept we talked about with alcohol? Guess what? It's back. It applies perfectly here too. Truncating mutations in that same TTN gene are found in about 15% of PPCM cases. So for these women, the pregnancy itself is acting as the environmental trigger. It's an immense physiological stress test that forces an underlying genetic cardiomyopathy to express itself. And it's a big deal because a positive genetic test in these cases unfortunately predicts a lower chance of the heart recovering its normal pumping function later on. Treating this is, as you can imagine, super delicate because you aren't just treating one patient, you're treating two. The mother and the fetus. Before delivery, you have to work incredibly closely with a maternal-fetal medicine team. We literally have to avoid some of the best standard heart failure meds, like renin-angiotensin system inhibitors, because they can harm the fetus. But once the baby is delivered, the whole strategy shifts. Then we can use medications like enalapril and spironolactone, which are safe for breastfeeding. Also, since a huge, poorly pumping heart has a really high risk of throwing blood clots, we usually prescribe anticoagulation postpartum, just as soon as the risk of obstetric bleeding goes down.
And finally, Section 4, Takotsubo, also known as stress-induced cardiomyopathy.
This one is honestly mind-blowing, and it's probably the most surprising trigger of all. It usually happens in older women right after a sudden, devastating emotional or physical shock. The name Takotsubo actually comes from Japan. It describes a narrow-necked jar that Japanese fishermen used to trap octopuses. And the reason we use that name is because when this condition strikes, the left ventricle dilates heavily at the bottom, the apex, while the top, the base, contracts super hard. The human heart literally morphs into the shape of this octopus trap. This right here is the actual medical condition behind the phrase broken heart syndrome. And you can literally see this octopus trap shape happening on an MRI. If you look at the image on the left, that's in diastole, the resting phase, and the ventricle just looks mildly dilated. But look at the right, that's end systole, when the heart is actively squeezing. You can clearly see that crazy apical ballooning. The middle and bottom sections of the ventricle are basically paralyzed, while the very top is just working overtime. If you see this patient in the ER, they look exactly like they are having a massive heart attack. Chest pain, crazy ECG changes, the whole shebang. But then you go to check their coronary arteries and they are completely open, no blockages at all.
So what's actually going on in there? Basically, it's a massive, absolute flood of adrenaline and stress hormones. We call it intense sympathetic activation. Because the nerve endings aren't distributed evenly across the heart muscle, this massive surge causes the tiny blood vessels to spasm everywhere, and the adrenaline itself is literally toxic to the cells in those amounts. The end result? The MRI will show diffuse myocardial edema. The heart muscle gets incredibly swollen. But here is the most crucial, fascinating part. It happens without cellular necrosis. That means there's no permanent cell death. And that is exactly why, in most cases, this terrifying severe heart dysfunction just resolves completely on its own within a few days or weeks.
Which brings us to our final takeaway today. We've just seen how a few too many drinks over the years, a buildup of iron in the blood, the profound physiological shifts of having a baby, or a sudden, devastating emotional shock can literally change the physical shape and function of the human heart. So I'm going to leave you with this. Is the heart really just a simple mechanical pump? Or is it a profoundly dynamic organ that responds directly and sometimes very dramatically to our environment, our chemistry, and even our deepest emotions? Thanks for joining me for this explainer. Keep learning, and I'll see you next time.